Good afternoon. Welcome to today's webcast entitled Improving Cervical Cytology Collection Techniques to Improve Accuracy with Dr. Craig Strafford, Director of Clinical Research, Holzer Clinic, Gallipolis, Ohio. Following the talk, we'll have a short question and answer session. You can ask questions at any time during the presentation via the web using your Ask a Question box. If you should need technical assistance, type your inquiry into the tech support box on the left side of your screen and click the Send button. If you are disconnected from the webcast, you can log on again using the instructions provided to you for accessing the webcast. If you cannot log back on in either of these ways, please call 877-843-9272. It is now my pleasure to hand over to your speaker, Dr. Strafford.
Thank you, Katie. The subject of the webinar this afternoon is Improving Cervical Cytology Collection Techniques to Improve Accuracy. The webinar overview, we want to achieve an understanding the role proper cervical collection technique plays in providing satisfactory and accurate Pap test outcomes. We also want to understand the clinical significance of an unsatisfactory Pap smear report and the clinical significance of the lack of endocervical cells within a Pap smear specimen. We also want to determine ways that may improve collection technique. We have a couple of polling questions to start the webinar. The first polling question is, what is a reasonable rate for unsatisfactory Pap smear reports to occur in your practice? Is it 2%, 1%, more than 5%, 4%? What do you think? Please vote now. Very good. The majority of respondents reported 1%. I think the most authorities would agree that it would be very normal to have an unsatisfactory report level between 1 and 2% of your Pap smears. If it's higher than that, possibly you would want to look at your technique and see if you can improve your results and decrease the number of unsatisfactory Pap smears, and that's what this webinar is all about. Second polling question. And according to the American Society of Colposcopy and Cervical Pathology, what is the percent of unsatisfactory Pap smears? How are they related, or how is that percent related to collection technique? So, what percent of unsatisfactory Paps are associated with the collection technique? Polling question. Your choices are 10%, 40%, 65%, 80%. What do you vote? It's not showing up on my screen. Hang on just a second. Okay. Very good. The majority of respondents are hovering between the 65 and 80%. I believe that most authorities would agree that 80% of unsatisfactory Pap smears are due to a variation in the collection technique. That's what we're going to be talking about. The next part of this presentation will discuss the relationship of specimen collection to Pap test outcome. The importance of cervical sampling technique for our patients. Proper cervical sampling technique facilitates the determination of the presence or the absence of cervical disease, and also gives us a basis for follow-up with our patients, including whether they need referral for colposcopy or for other diagnostic services. Sampling errors lead to false negative results. In other words, the patient has disease, but we don't detect it because we didn't pick it up. The effects of poor sampling technique. Unsatisfactory specimens are 80% due to the collection technique. There are additional faults with the Pap smear that can be related to labeling problems, specimen vial leakage and vial breakage. We're going to talk later in this presentation about ways to avoid those problems. The largest problem with unsatisfactory pap smears is that we fail to collect sufficient squamous material in order to do the pap smear. So insufficient squamous cells. Also, there is interference from obscuring artifacts such as lubricant, menstrual flow, excessive mucus, inflammatory byproducts of vaginal infection, and recent intercourse. We want to increase the the false negative rate is increased by poor sampling technique. We're also going to talk about the significance of the lack of endocervical cells in a pap smear report. It can reflect atrophic or menopausal changes. Let's look at a specific example of what a satisfactory versus an unsatisfactory specimen would look like. The topmost oval is an ideal specimen which is satisfactory for interpretation. The next down oval represents scanty cellularity, which is the chief reason for which pap smears are unsatisfactory, followed by an oval showing excessive lubricant within the pap smear. We're going to talk about the use of lubricant with obtaining the pap smear later on. And then the lastmost oval shows bloody contamination either from menstrual flow or from a collection technique fault. The clinical significance of an unsatisfactory specimen. Unsatisfactory specimens may hide the potential of underlying disease, as we've mentioned. If you do have an unsatisfactory specimen, what should you do? Current best practice recommendation would be to repeat the pap test within 2 to 4 months. If there is a specific reason for which the pap test was unsatisfactory, endeavor to eliminate that condition. If it's obscuring inflammation, that can be treated. If it's a matter of patient education, that is also an opportunity so that the patient returns able to have a satisfactory pap smear. Additional clinical evaluation may be necessary if the patient has symptoms that are abnormal on her examination, such as the examination is unsatisfactory because of obscuring blood or inflammation. What is the relevance of the endocervical component? Endocervical cells are generally considered to be a quality indicator of specimen collection. The presence of endocervical cells or the absence does not make a pap smear satisfactory or not satisfactory. It is perfectly reasonable to have a satisfactory pap smear that is available for interpretation that does not include endocervical cells. It may be a pregnant patient, it may be a patient who is postmenopausal. Separate from that, what are the indications for a repeat pap test at an early interval? If the patient has a prior abnormality without 3 consecutive negative pap tests, one of which should include endocervical cells. Another indication for a repeat pap test would be a patient with a human papilloma virus, high-risk strain positive pap smear, even and including the pap smear itself being negative. If you are unable to visualize the cervix or sample the endocervical canal, if you can't see the cervix, you can't get a pap smear. If the patient is under immunosuppression or if there is insufficient previous screening, these can all be reasons to repeat the pap smear at an early interval. Why do cervical sampling errors occur? This slide shows the multi-step clinical testing process. We are not going to review all the steps. We are only going to focus on the specimen collection portion of this continuum. What factors do contribute to sampling error? Sampling error is most frequently inadequate patient preparation, including insufficient collection of cells. Sometimes a broom-type device is unsatisfactory for capturing the zone of transformation. The patient can have excessive discharge, blood, and lubrication, both the lubrication that you use on the speculum and lubrication the patient may have used for her own benefit. Dysplastic cells can be not properly captured. This can be because you didn't sample them properly, or they weren't properly collected in the transport media and aren't available for the cytotechnologist to look at. Another reason for sampling error is the lack of recognition of abnormal cells by the laboratory or by the cytopathologist. We'll talk about some details of that in just a few minutes. Factors that influence the collection technique. Patient preparation for testing is an important opportunity. The patient should avoid recent intercourse, active menstruation, the use of unapproved lubricants, and the use of internal sanitary protection. I think it's reasonable to ask patients to avoid intercourse, not being menstrual, and avoid the recent use of internal sanitary protection within 48 hours prior to the patient's presentation for pap smear. There is also patient preparation involved in you visualizing the cervix at the time of trying to obtain the pap smear. Occasionally, there is the opportunity to remove a scant amount of menstrual flow or mucus that would be obscuring visualization of the cervix. This can be accomplished with the use of a large cotton-tipped applicator. Device selection for collection is another important consideration. Sampling the endocervix with a brush and using a spatula for the endocervix, a brush for the endocervical or for the canal into the uterus is appropriate. We'll talk about collection devices in a moment. Compared to a Dacron swab, the Cyto brush is probably a more useful collection device. The studies have shown a decrease in the unsatisfactory rate from 14% to 3%, an increase in the detection of atypia from 10% to nearly 17%, and an increase in the detection of high SIL changes from 1.7% to 3.7% using a collection device other than a Dacron swab. To reinforce the appropriate technique, I think it's appropriate for us as clinicians to commit to proper collection technique and to encourage our staff to assist in the process of appropriate labeling and shipping of the specimens. If you find that your unsatisfactory rate is above 2%, it may be appropriate to go back and look at your technique and see if there's an opportunity to decrease the unsatisfactory rate by making changes to your collection technique. Good laboratory practice as far as your reference lab is concerned includes a lab that uses accredited cytotechnologists and pathologists with defined workload limits and labs that use internal quality improvement programs. It's probably not something that we're going to deal directly with as clinicians, but the opportunity is to ask your lab for their statistics in how they have implemented quality improvement programs in their part of the process for processing your specimens and providing you with pap smear reports. Let's overview the proper collection technique for thin prep pap tests. Using the brush spatula collection device combination, it is recommended to first use the spatula and to rotate the spatula 360 degrees around the ectocervix while maintaining light contact with the exocervical surface. The speculum can be introduced using lukewarm water as a lubricant. That never seems to work for me, so I use a water-soluble lubricant that has been appropriately approved by the cytology lab that I use. But I think the important point is to lightly coat the posterior blade of the speculum with the lubricant, and to be sure that there is not an accumulation of lubricant in the bowl of the blade so that it goes against the cervix and you end up sampling the lubricant instead of the patient's cervix. After swiping the spatula around the cervix 360 degrees, rinse it vigorously in the preservative solution 10 times. Counting to 10 is not unreasonable, because that will enable you to collect the material that you have captured, the material that you've collected. I think too that it should be noted that frequently right-hand operators will miss disease that is in the 6 to 9 o'clock position on the cervix, and left-handed operators will miss disease that is in the 3 to 6 o'clock position on the patient's cervix because of turning our wrist over as you rotate the spatula through the full 360 degrees. As far as the endocervical canal is concerned, it is appropriate to use a cyto brush. Introduce the brush until the majority of the brush is within the endocervical canal, and it is necessary only to turn a quarter to a half turn. Do not over-rotate the brush. That will contribute sometimes to bleeding. The need to rotate the brush only a quarter of a turn is because the brush has bristles all the way around, and you're sampling all of the endocervical tissue with just the quarter turn. Again, rinse the brush vigorously 10 times in the fluid, pushing the brush against the side walls of the specimen bottle so that the cellular material is recovered and put into the fluid and not thrown away on the brush. After the specimen has been collected in the vial, be sure that you tighten the vial with the black mark going past the comparable black mark, the black mark on the lid going past the black mark on the vial. In this manner, you can be sure that the vial is closed tightly enough to transport the material without leakage. Then record the patient's name and identification number on the vial, and record the patient's name and identification number on the cytology request form, package it appropriately for transportation, and the pap smear specimen is on its way. An alternative collection device would be the Broom-like device. It is used slightly differently, and we'll describe that. To obtain a satisfactory specimen with the broom, introduce the longer bristles in the middle of the brush into the endocervical canal, and then rotate the broom 5 times around. This will ensure the collection of the cellular material both from the endocervical canal and from the portio of the cervix. Again, as with the brush and the spatula, rinse the broom vigorously in the collection vial 10 times, forcing the bristles down into the bottom of the collection vial so that the material for evaluation is removed from the broom. Again, the bottle is closed in the manner as previously described. That is, be sure the vial is tightly closed so that it won't spill. Label the vial, fill out the pathology request form, and package it appropriate for shipment. From the literature, what is the impact of the collection technique? We're citing only one reference article in this particular webinar, and that is from Reb and others. This was a practice of 5 clinicians. They had a practice goal of improving their pap test quality, reducing their unsatisfactory specimen rate, and increasing the capture of the endocervical cells, and reducing their false negative pap results. They made a deliberate commitment to evaluating their technique and to improving their technique. 2 physicians in their practice did not participate, 3 did, and what they noticed was a marked improvement in their collection results. They had more specimens with endocervical cells shown, fewer specimens with unsatisfactory test results, and improved their detection of cervical intraepithelial neoplasia. My slide is not advancing. We'll see if we can fix that. Case studies. We have a few case studies to illustrate some points that we've been trying to make. The first case study is that of a 21-year-old woman. Her Pap test is returned as unsatisfactory for evaluation, no cytologic diagnosis. What is the next most appropriate step to take? Repeat the patient's Pap test in 2 to 4 months. Obtain the patient's Pap test when she returns next year. Repeat the Pap test in 2 to 4 weeks. Ask the patient to return in 6 months for another Pap test. Very good. 100% of the respondents to this polling question have answered repeat the Pap test in 2 to 4 months. That is generally considered to be the most appropriate management. I would add 2 other points. One, the last option in this first case study was to re-evaluate your collection technique. That's probably appropriate. The other point to be made is that these case studies are illustrations of possible patient management questions. They are not designed to demonstrate any right or wrong answer. They are merely ways that the patient might be managed. The next polling question is that of a 31-year-old woman with a previous unsatisfactory Pap smear 3 months ago, and she returns and her Pap smear is again unsatisfactory. What would you do next? Repeat the Pap smear in 2 to 4 months. Try obtaining a Pap test 2 weeks after her next menstrual period. Obtain colposcopy, or ask the patient to douche and return next week for a Pap test. Again, 100% of the respondents have suggested to repeat the Pap test in 2 to 4 months. That is a possibility. However, a significant number of experts would recommend obtaining a colposcopy. You've had a 6-month, at least a 6-month time period during which you could not obtain a satisfactory Pap smear evaluation. It may be appropriate to look with a colposcope. The next case study, your patient is a 29-year-old woman with 2 consecutive Pap test results reported as unsatisfactory, no cytologic diagnosis. You provide colposcopy and do not see any abnormal changes. A random biopsy is negative. When do you recommend that your patient return for her next Pap test? The choices are 6 months, 12 months, 2 years, or 3 years. And we have a technical opportunity here. Hang on a second. Question 5. Very good. And the majority of respondents are between 6 months and 12 months. I believe that a large number of experts would recommend simply repeating the patient's Pap test at 12 months. Fourth case study, your patient complains that she frequently has heavy vaginal secretions. You start to obtain her Pap test and observe copious mucoid material in the vaginal vault, completely obscuring your view of her cervix. What is your next step? Ask the patient to return after douching. Take a large cotton tip applicator and wipe away some of the mucus. Proceed with collecting the specimen for a Pap test. 100% of the respondents have indicated trying to use a large cotton tip applicator to remove the excess mucus, and I think most experts would agree that that is the appropriate next step. Very good. Last polling question and last case study. Betty is a 52-year-old established patient who has been coming to your practice for more than 20 years. Her recent Pap test is reported as satisfactory, negative for intraepithelial lesion or malignancy, endocervical cells absent. What should you do? Ask Betty to return in 2 to 4 months for a repeat Pap test, obtain colposcopy, repeat her Pap test in 12 months. The majority of respondents are leaning toward repeating the Pap in 12 months, and I think most experts would also agree with that management plan. There would be some, however, who would suggest simply repeating Betty's Pap smear in 3 years with the current 3-year guidelines. In conclusion, improving cervical cytology technique is important to limit the number of unsatisfactory Pap smears that you receive and to avoid missing undetected disease. The accuracy of cervical cytology outcomes may be improved by reevaluation of your collection technique, including the sampling device that you use, and the utilization of liquid-based rather than conventional glass slide Pap smears. Also assessing your workflow in your clinical practice, including specimen processing. Practical tips to incorporate into practice include patient education. Ask your patients to avoid having intercourse, using tampons, having menstruation, or excessive vaginal secretions prior to presenting for their Pap smear. In terms of patient preparation, be sure that you use lubrication sparingly on the posterior blade of the speculum, and that you do not allow lubricant to pile up or collect in the bowl at the distal end of the speculum, thereby putting it against the cervix and collecting lubricant rather than cellular material. Monitor your processes for specimen collection and handling, and reinforce with your office staff the proper cervical collection technique. I suspect that this frequently would center on having your aide who may be swishing your brush, your spatula, or your broom the full 10 times and pressing it against the sidewalls of the container so that you collect the cellular material that was picked up with the brush. And I believe that concludes the formal part of the presentation. I'd be pleased to try to respond to any questions, and I most certainly want to thank all of you for your attention. I hope this webinar has been helpful. We have tried to emphasize compulsive behavior in specimen collection in order to net or result in the fewest number of unsatisfactory specimens for you and the patients for which you provide care. Question number 1. My Pap usually comes back satisfactory, but absence of transformation zone cells. Any recommendations? I see the description of transformation zone cell much as I do the description of endocervical cells. I would, as long as the Pap smear is listed or designated as satisfactory and no cellular abnormality is seen, I think you can go with that Pap smear. If this is one of the cases where you're trying to get 3 negative Pap smears in a row so that you can spread out the frequency of testing the patient, it would be appropriate to have endocervical cells in at least one of those smears. Second question. Had a patient with an ascus Pap smear and reflexed HPV. HPV came back unsatisfactory. Why? The most frequent cause of unsatisfactory human papillomavirus screen is that your original Pap smear did not have enough cellular material to be able to do both the Pap smear and the HPV screen. Frequently, and particularly with the ascus patient, that may be a factor in the patient's management, so that you would want her to come back for a attempt again at obtaining the high-risk human papillomavirus screen. The next question is, how do I know that the lubricant I am using is okay? An appropriate method or way to answer this question would be to check with your reference laboratory and see what they say. In general, water-soluble lubricants that do not include carbomers or polymers thereof, some examples would include Surgilube, Astraglide, Crystella, and also KY if you can still find it in the sterile form, KY jelly. Check with your reference lab. They would tell you if the specimen or if the lubricant that you're using is confusing their evaluation of your specimens. And I don't see any further questions. Again, I want to thank you sincerely for your participation in the webinar. I think that we have reviewed the collection technique, and I think that the two things to remember are, if you can't see the cervix, you can't get a pap smear, and if you can see the cervix, careful attention to detail will afford you the minimum number of unsatisfactory reports and the maximum number of non-failure to detect disease. Thank you very much for your time and attention. I hope the rest of your day is most satisfactory. Goodbye.